speaker, expert in neonatal hemodynamics. Some might even call him like the godfather of neonatal hemodynamics, or maybe I just made that up right now. We're really grateful to have him back. The last time was in 2003, where he came in and stepped in for Dr. Reagan Giesinger, who was supposed to speak on this very exact topic. So we're really appreciative of this. She was clearly the expert and did some really groundbreaking, fantastic research on the area of hemodynamics and HIE during TH. So thank you, Patrick, for joining us again, and I'll let you take it away.
Thanks, Clara. And it's nice to be able to be back talking to this group. You know, as Clara has pointed out, you know, I gave that talk May the 16th, 2023, which I think probably the last time that kind of we've had this, you know, webinar, and it was supposed to have been Reagan's talk, and you know, that day had so many kind of ripple effects, some of which you guys probably don't know as much about. But I remember, you know, she died at 3 o'clock in the morning. I think the talk was like a midday talk, and I spent the whole morning debating with myself whether I do it or not. And then I decided to do it because in her honor. But the first 5 minutes, I basically cried. And to cut a long very story short, you will see that I am the Reagan Giesinger Professor of Neonatology, and what happened was that a set of donors who are currently contributing to a chair position, so it will grow to be a chair over the next few years, somehow got hold of that talk or heard about it. And when they saw how much her life had impacted me for that first 5-6 minutes, they were so kind of blown away by what she meant to the world of hemodynamics that they asked for that kind of endowed chair or professorship of $1.5 million to be named after her and not after them. So you guys indirectly had a huge influence on the naming of the Reagan Giesinger Professor of Neonatology in Iowa. And her name will be forever in the legacy of kind of Iowa neonatology and actually now US neonatology. So I'm going to be speaking on kind of really something that started off when Reagan was a trainee kind of at SickKids in Toronto, and tried to tell the story of the uniqueness of the hemodynamics of HIE and how it may influence care. So I don't need to go into too much details about this, but all of you are aware that following a significant hypoxic-ischemic insult, a cascade is initiated that has got very many components. There's an ischemic component, there's an inflammatory component, which ultimately lead to immediate necrotic cell death. So some cells are going to die. You know, this is very important. We talk to our trainees, you know, oftentimes people fall into that trap that we're cooling the baby to protect the brain. When you decide to cool, there's some of the brain that's already damaged, okay? And we're trying to mitigate the risk of secondary energy failure, meaning that as a result of all these cascades, there's anaerobic metabolism. And if you don't interrupt that process, cells will die by this process of secondary energy failure and apoptosis. Again, we don't need to go into details. Therapeutic hypothermia has probably been the most revolutionary intervention in the last 20 years. The benefits are significant, the benefits are consistent. But remembering that the trials were specific to a certain patient population. So term babies, not babies who are 33 weeks gestation, babies with severe pulmonary hypertension, who represent the sickest babies, were not included in the trials. And the other extrapolation, as you all know, is when is the time to say that you can't cool? And many people, including myself, have cooled babies beyond 6 hours, based on the premise that 6 hours comes from time in the life of a rat or a pig, which is not necessarily the same as a human. The issue is that despite this being a highly effective intervention, up to 40% of patients will either die or will be left with major neurocognitive sequelae. And the question that Reagan posed was, could there be a link in some way to hemodynamics? And it's important because much of the research that's being conducted in this kind of non-responsive population has been looking exclusively at brain-specific interventions and not necessarily recognizing that how the heart, how the kidneys, how nutrition, these things may all have a role in the injurious process. So everything oftentimes starts off, and this is very much the theme in hemodynamics. You know, we have this world whereby we're looking at sick babies and complex babies every day. We have formal daily reviews. We go through these cases, and every now and then there'll be things that don't make sense. And this particular patient was a 12-hour-old infant, was profoundly ill with hypoxemic respiratory failure, huge dose of dopamine that had been started for hypotension in the community hospital, and the baby was transferred into us. But the brain showed severe injury. The baby had an echocardiogram, and this is a long axis view, and you can see that the left ventricle at the bottom is squeezing very nicely, but the RV at the top was just rocking. So we thought, pulmonary hypertension baby, RV dysfunction, that's not a big surprise. But then we started to notice that more babies were having RV dysfunction than LV dysfunction. So if we think about, brain injury, there's so many contributors to cellular homeostasis, much of which we've already talked about before, but cerebral blood flow is an incredibly important component of it. And if you have dysregulation of perfusion of the brain, that's not necessarily going to help, this injurious process. So if we think about it, we've got these phases in which you have the primary insult. And if we think of the cerebral circulation as this process of energy cellular failure is happening, there's variations in ischemia, hypoxia, followed by kind of reperfusion, increased oxygenation of the brain, and then potentially reperfusion injury. And, none of this really had, paid much, attention to in the research conducted to date. So if we now take this concept that oxygenation of the brain, perfusion of the brain are important, and we start to think what goes on from a cardiovascular perspective, and this came from a review article we wrote in 2016, you can see it's very complicated. With the primary hypoxic-ischemic insult, there may be heart dysfunction, there may be pulmonary hypertension, or there may be adrenal gland insufficiency, and all of these things will contribute potentially to changes in cardiac output, which may lead to worsening of the ischemia. We then add on the effect of hypothermia, which may influence heart rate by dropping it, may influence pulmonary vascular resistance. We don't know much about the effect on heart function. So we have these additional modulator effects of hypothermia on the cardiovascular system. And then finally, we have the rewarming phase in which the heart rate goes up, okay? The blood pressure changes, cardiac output will increase. That theoretically may lead to reperfusion injury. And if we think of what most people do in the setting of HIE, it's a very, very simplistic approach based on blood pressure, which doesn't really take into account the changing paradigm that occurs both during cooling and then during rewarming, and what might be the additive impact to the brain. So kind of in around the same time, Reagan published this kind of consensus, or not consensus, a survey in which she looked at 71 academic centers across the United States, where there were 71 respondents. And she asked the question, how do you define hemodynamic stability? Most people said it's based on arterial blood pressure, but the scary part is that there were 17 different definitions used of what actually constituted an abnormal blood pressure, which is somewhat concerning if you're trying to come up with better ways to modulate the brain. The other interesting thing from the observation is that echo was almost rarely performed. Okay, kind of 40% of centers would not perform an echo even if they're providing cardiovascular support. And again, you've heard me talk about this before. It's based on this premise that people treat blood pressure or low blood pressure as a disease rather than what might be the biological contributors to having low blood pressure. And in addition, even in centers that perform echocardiography, and this again is not a surprise to the people on the call here, most of the evaluations are subjective. It's the eyeballing. and rarely is cardiac output performed, because a lot of these echoes that people get are what I call.
I didn't approve no. I didn't approve no. The 28.
An sorry. Okay, so an etymology in which people are actually looking more at the structure of the heart as opposed, and then making an interpretation of the physiology. Is echo important in the same HIE because when you think about it, how reliable is our clinical state? Okay, we pay a lot of attention to color, lactate, blood pressure, perfusion. Okay, but how reliable are they in the setting of HIE? This is an interesting study on the left-hand side, kind of showing that there's a very strong relationship between elevated lactate and the severity of the ischemic insult, which all of you know. Not a big surprise. But more importantly, this study here, looking at the relationship between cardiac output, okay, and looking at lactate clearance, what you can see is that lactate clearance has got a very poor relationship to cardiac output. So the babies with the lowest output had the highest clearance, and vice versa. The highest cardiac output had the lowest clearance. So, lactate is not a very good measure of the adequacy of the circulation. Similarly, what about urinary output? We all know that kind of asphyxiated babies become olivuric. Okay, and again, this data here again shows it's commonly associated with HIE, but urinary output falls also as temperature falls. So the ischemic insult to the kidney interrupts the value of urinary output as a predictor, as does hypothermia, which again becomes a big concern. So we've already talked about this before, so our clinical exam may not be very helpful in identifying clinical states that are concerning, but on the counter, perfusion of the brain is important. And there's certainly significant evidence showing a relationship between heart dysfunction, okay, and kind of worse brain injury, suggesting that, perfusion to the brain is something we need to think about. So how do we better evaluate, kind of the adequacy of the cerebral circulation, and what is the role of cerebral nears? Abnormal cerebral nears is consistently tied to abnormal outcomes, but it's the opposite to what you expect. Where unlike other situations of cardiovascular instability, the presence of high cerebral nears, okay, and low variation in nears are prognostically very concerning. And the high cerebral nears relates to the fact that if the brain is so badly damaged, extraction of oxygen is going to be much less. So in looking at here, the graph on the right-hand side is looking at variability, and you can see that, less variability also in the black boxes was associated with more severe HIE, kind of more abnormal AEG, and abnormal outcomes. So high cerebral nears, lack of variations are probably not good prognostic features. Looking at the cerebral perfusion itself, and these are some studies looking at Dopplers of the middle and anterior cerebral artery, having higher diastolic flow like the one in the middle here, and as a result, a lower resistance index, again, are poor predictors or predictors of poor neurodevelopmental outcome. And then finally, this other study here, again, looking at kind of flow in the middle versus the cerebral artery, babies with more severe HIE had higher systolic velocities in the middle cerebral artery. And particularly, as you can see, as you go later into the rewarming phase, this became more apparent, which again is not a surprise. How useful is echo? And kind of one of the early studies conducted with echo were actually looking at left ventricular function. Arvind Segal's study and Eric Nesta's study showed that more asphyxiated babies had kind of more abnormal LV dysfunction, but you will notice not a word about the right ventricle. And in addition, these studies did not look in any way at the relationship between kind of LV function and abnormal neurodevelopmental outcomes. They looked in a very superficial way and didn't find an association, but it was not a very strong study, and these were very small numbers. Where things started to change, again, as the world of hemodynamics started to evolve, more neonatologists getting interested and involved in cardiovascular research. And this is Ori Hochwald, who was a Vancouver hemodynamics trainee that spent some time in Toronto and now is back in Israel, actually did this very small study looking at babies with abnormal versus normal MRI and demonstrated that during the rewarming phase, cardiac output was higher, particularly SVC flow was higher in babies with a more abnormal MRI, and for the first time suggested this concern that perhaps hyperperfusion may be a problem. So babies that maybe get treated for low blood pressure and stay on medications, when they're rewarmed, their cardiac output goes up, their heart rate goes up, those babies potentially are at risk of kind of reperfusion injury. So why might there not have been very much kind of with respect to the right ventricle? And as I mentioned earlier, you know, in most centers, most echocardiograms are performed kind of by pediatric cardiologists, which very much focus on primarily on the anatomy. So most of the hemodynamic information is limited to subjective assessments. There is a PDA that's of a certain size, looks small or looks large. But from a pulmonary hypertension perspective, much of the evaluation is based on subjective determination of RV contractility, RV size, septal flattening. So we did this study in which we looked at a cohort of 60 babies. 30 of them had pulmonary hypertension, 30 were normal. We asked 6 experts 3 questions. Is the right ventricle dilated? Is the septum flat? Is the RV dysfunctional? And these are the kappa coefficients. So a kappa of 0 means there's no relationship between individuals. A kappa of 1 means that the relationship is strong. So you can see here the kappa for subjective assessments put by experts and novices is very poor, meaning that subjective assessment is probably not very reliable. So now in an era whereby there are more objective ways to quantify RV contractility, and these are some of them, I'm not going to go into details. TAPSE, which looks at the vertical displacement of the tricuspid valve, right ventricular fractional area change, and something called strain analysis. And we perform a multi-parametric assessment in which we measure all these things to give a much more objective way of evaluating contractility. So based on the uncertainty in the literature and based on Reagan's hypothesis that perhaps the right ventricle is important, she conducted this very large study of 60 babies who had multiple time point echoes. You can see at 4 to 5 time points. And they had continuous vital sign monitoring, AEG, NIRS, video EEG. So a very, very comprehensive multi-parametric study, multimodal study. So what did she find? Well, the first thing is not a big surprise. Babies with more severe HIE had more severe heart dysfunction. And you can see this significant reduction in contractility. What was different to the other literature is when you compare this to the left ventricle, the indices of LV contractility, both ejection fraction and global strain, really, although they changed over time, okay, these values were not much different to what would constitute normal term corrected data. Compare the values of the RV and look at the severe TAPSE of 4.8 versus a normal of 9.2. FAC of 26% versus 39%. So the RV was much more abnormal than the LV kind of in these babies. So when Reagan went on and then looked at the effect of changes over time between the first 2 cooling echoes and the rewarming echo, what she found was that things changed in both groups, both in the normal and the abnormal over time, but the abnormal brain injury group defined by death or abnormal MRI had significantly lower TAPSEs, FACs, and right ventricular output. But the LV didn't distinguish between normal versus abnormal, suggesting that kind of RV function may be a significant predictor of dysfunction, of abnormal outcome. These are the ROC curves you can see for both TAPSE and FAC. So it's a pretty strong prediction, such that a TAPSE of less than 6 had a area under the curve of 0.83 and an FAC less than 0.3 had an FAC of 0.88. The most important part was when we adjusted for illness severity and severity of HIE, TAPSE independently, and FAC were independent predictors of an abnormal outcome. So that's important. This is not just more asphyxiated babies have worse function and worse brains. There's something independent that seemed to matter. In looking at the relationship of these findings to cerebral oxygen saturations, what we found, again, compared to similar literature, that infants with low cardiac output still had higher cerebral oxygen saturations, again, demonstrating the poor reliability of cerebral oxygenation as a predictor of cardiac output, but higher cerebral sats were seen in the patients with a more severe adverse outcome. Again, shown this another way here. If you look at the graph on the right-hand side, you can see higher outputs had lower cerebral oxygen saturations. So cerebral oxygen saturations are not necessarily a good predictor of the adequacy of the systemic circulation. How good is blood pressure? So we looked at infants that were treated with vasopressors versus those, or uninterrupted vasopressors versus those that did not. Okay, and what we actually demonstrated is that, if you're comparing those babies independent of normalization of blood pressure, the RV was still dysfunctional. So they're the infants who were given drugs. You can see their blood pressures had recovered to normal, similar to the control group, but they still had evidence of subclinical heart dysfunction. And when we looked at this in a ROC graph, blood pressures really and indices of LV dysfunction were much more worse predictors of brain injury than babies that had significant changes in TAPSE or fractional area change. Reagan didn't end there. She wanted to look at what's the impact at 2 years of age, and this is the predictive model here, showing that in survivors, TAPSE was a very strong predictor with an area under the curve of 0.9 of adverse neurodevelopmental outcome, but also so was FAC. So this predictive value goes beyond the NICU. So at that point in time, and again, we had come to the US, we were here in Iowa, some of the questions that Reagan had, okay, we know that the RV means something, but the questions are, why is the RV more impacted than the LV? What does therapeutic hypothermia, how does it impact this? And what's the relationship of cardiovascular treatment to brain injury? So biologically, the RV is different. It's got a very different blood supply and metabolic activity, which is higher, particularly in the transition period. Unlike the left coronary artery, which is only perfused in systole, the right coronary artery is perfused in systole and diastole, so it's much more vulnerable across the cardiac cycle. And then the shape of the right ventricle, with a higher ratio of its radius to wall thickness, makes it much more prone than the LV to wall stress. Again, some nice examples here. You can see this is the stress-velocity relationship that you probably have heard me talk about before, in which higher afterload leads to a much further reduction in contractility. And you can see that the neonatal myocardium, okay, that the slope of the line for the RV is even more steeper than the LV, okay, and more steeper than the adult, which is got a much lower slope, meaning that the RV, for the same change in afterload, will have a much more significant decrement in contractility. And that's not just made up. The graph I showed you came from this paper here, which it looked at children in the cath lab, and you can see a much steeper slope for the RV line than for the LV line. And this becomes very important in managing these babies. If they do have heart dysfunction, remembering that oftentimes this is associated with pulmonary hypertension, and particularly the drugs we give for blood pressure, if they are vasoconstricting the pulmonary vascular bed, will have a negative impact on this stress-velocity relationship. So which gets to, in managing the RV, it's important to recognize that things that will influence negatively pulmonary vascular reactivity, the wrong type of cardiovascular agents, dopamine, high dose, norepi, potentially norepi, hypoxia, metabolic acidosis, lung disease, kind of overinflation on the ventilator, et cetera, will all lead to pulmonary vasoconstriction, which will have a negative impact on RV afterload, pulmonary blood flow, and potentially through ventricular-ventricular interaction, the LV, leading to a low cardiac output state and worsening brain injury. So what about the effect of cooling itself? So Angelica Vasquez kind of was a former hemodynamics fellow here, and with Reagan performed this study, small study, this probably will never be repeated, in which we performed echocardiograms before the initiation of cooling and after the initiation of cooling. And what you can see here is that, not surprisingly, the indices of pulmonary vascular resistance, this ratio of RV ejection time to pulmonary artery acceleration time, notching of the pulmonary artery, Doppler, and the amount of right to left shunting across the ductus increased, but RV contractility changed very little, okay, at least at the initiation of this, suggesting that it can have an effect on the RV, and at least in this cohort here, although PVR went up, RV function remained kind of okay. This obviously may have a very different effect on much more critically ill babies that we need to pay attention to. What about the effect of cardiovascular treatments? So if you actually look at the literature, we all know that dopamine increases blood pressure. We know it's the most common drug used for hypotension, both in preterm and term babies. However, when you look at the relationship to death or abnormal MRI, infants who received dopamine were more likely to have a worse outcome. And you can argue that it's because maybe they were more hypotensive. But the question is, could there be an independent effect? To try to get some answers to the question, we have to really pay attention mostly to the pulmonary hypertension type of literature. And this study by Manacheri, this has also been repeated by Keith Barrington, and Satyan has done a very similar study where they looked at the effect of high-dose dopamine, which is the lighter shade of gray, or so the darker shade of gray, black, versus a combination of moderate dose dopamine of 10 and epi of 0.2. And they looked at the effect on blood pressure, pulmonary artery pressure, and the pressure gradient across the ductus arteriosus. And what you can see is that both strategies increase blood pressure, but they increase pulmonary artery pressure to a much greater extent. So if you are trying to reverse the pressure gradient between the pulmonary and systemic circulations, these strategies don't work. They actually push it in the opposite direction, which is negative. So does this mean anything? Well, we performed this study here between the sick kids approach, which is predominantly based. So we will basically not chase the blood pressure at all costs. And if there was low systolic blood pressure, we may start dobutamine. If the echo showed heart dysfunction, we may start dobutamine or low-dose epinephrine. In Hungary, it was very much everybody was given dopamine and everyone was given hydrocortisone as a mandatory kind of approach if the blood pressure was low. But you can see a lot more babies were untreated in sick kids and a lower instance of hypertension. This is in the early phases of echo in Toronto, so only half of the babies actually had echo-guided care, as opposed to 27% in the Hungarian study. What do we find? Overall, the instance of the composite outcome was no different. However, when you actually looked at the detail, most of the babies in Toronto had more minor brain injury. There are some that had basal ganglia injury, but the instance of basal ganglia or more severe injury was much higher in the dopamine treated center. So I've shown you this before. You know, this actually Amira Shrafi shared this with me, the dopamine molecule and its resemblance to a character we don't like to think about very much. You know, and again, the HIE literature for me really puts another nail in the coffin of why dopamine is probably not a good drug in this situation. It increases the blood pressure. But again, to try to find any evidence that it helps these babies, I can't find any. And I think it's no longer acceptable to say this is what we always did, so that's what I'm going to continue to do. That's not how a scientist thinks. The other thing to think about with the right ventricle, and given the fact that these patients may often have pulmonary hypertension, one of the next questions is, well, why dobutamine? Or why low-dose epinephrine? Why not milrinone? You've got Again, there's no randomized controlled trial data yet of milrinone in term babies. We did this pharmacological study in Toronto in showing that it does improve heart function in the setting of pulmonary hypertension through its vasodilator effects. It also improves the adequacy of oxygenation and so forth. But the impact on outcomes in the randomized trial setting, we do not yet have data. Satyan will have his data from the CDH study, but nothing in the non-CDH pulmonary hypertension. We stumbled across the fact that milrinone may not be a good drug in HIE the hard way. Anecdotally, we had some cases of babies that were treated with milrinone and their blood pressures fell off the roof. Okay, so we went on and did this study here when we looked at 3 groups of babies. Okay, the green boxes are babies who received milrinone. Sorry, these are babies who were asphyxiated with pulmonary hypertension who did not get milrinone. The graph on the left is systolic blood pressure, the middle is diastolic, and the right-hand side is a vasoactive inotrope score. And you can see systolic and diastolic pressures were stable, as was the vasoactive score. The purple triangles are infants with pulmonary hypertension, but no HIE, who received milrinone in the first 72 hours. Again, a very stable systolic and diastolic blood pressure and a stable vasoactive score. The red circles are babies with HIE who received milrinone for pulmonary hypertension. And you can see a very rapid reduction in systolic and diastolic blood pressure, which prompted the discontinuation of milrinone. But you can see their vasoactive score, not only did it go up, but it stayed high for more than 24 hours. So we now kind of don't use milrinone fairly aggressively in this patient population. We use it in a much more selective manner. So, what can you do? Again, first is recognizing that different drugs have different properties. Okay, drugs like vasopressin or epinephrine are predominantly vasopressors. Drugs like dopamine and epinephrine have got both vasopressor and potentially inotropic effects. And dobutamine is an inotrope. Milrinone is more of a vasodilator, but certainly in the setting of HIE and particularly HIE with hypotension, probably milrinone is not a drug during the cooling phase. And our hypothesis is that because it's cleared by the kidneys and metabolized by the liver, the ability to clear milrinone is less. So you may end up with getting toxic levels in the circulation. So this is kind of our framework, and is very much based on systolic and diastolic blood pressure. So if the baby has low diastolic pressure, again, can happen in the setting of HIE because of sepsis or adrenal gland, using vasopressors that are friendly. If norepinephrine is probably a good drug in babies with lower oxygen requirement, but in higher oxygen requirement, because we know norepi may have more pulmonary vasoconstricting effects, that may be where vasopressin is ideal. If the problem is low systolic blood pressure, okay, again, is the patient hypoxemic and you go down the pulmonary hypertension pathway? Okay, if they're not, echocardiogram may be helpful in differentiating RV versus LV function. And you can see that most of the time we would be recommending we recommend dobutamine or low-dose epinephrine. In our experience, if you don't respond to up to 7.5 mics of dobutamine, giving more dobutamine is not going to help. So we then traditionally would transition those babies to low-dose epinephrine in that setting. Occasionally, we may need to use prostaglandin if the LV is, or if the RV is very bad. So the next question, is there a value to early echo screening? Okay, why wait for the babies to get sick? You're familiar with our data in extremely preterm babies that screening may be beneficial. Is there any value to screening these patients? I don't have the answers yet, but maybe in a year's time we'll have the answers. One of the cases that actually prompted the benefit or why we should start thinking about screening was this baby here who was an outborn infant, asphyxiated, had prolonged resuscitation with need for chest compressions. By 24 hours, this baby was doing relatively well, was in room air, kind of had normal blood pressure. The lactate was high, had been on therapeutic hypothermia. And sorry, this was not 24 hours, this was in the first 12 hours. as part of the approach in Iowa, based on kind of Reagan's data, we did introduce mandatory screening for this patient. This is the baby's echo. And I remember Adrienne Bischoff was the fellow. This is about probably 4 or 5 years ago. And she came to my office and said that she looked at this baby and things didn't look quite right. She said that the LV was really badly affected. And severe LV dysfunction with a normal RV is unusual to us in the setting of HIE. Most of the babies that do have LV dysfunction, it's because the RV is very, very bad. So I came and looked at the echo with her. So again, bad strain, bad ejection fraction. And when we looked at the echo, what we actually found, you can see here in the middle picture, there was a thrombus that was coming out of the left coronary artery. Okay, that basically was leading to kind of ongoing myocardial ischemia and infarction. So we reached out to our cardiology colleagues. We went to the cath lab and ended up receiving intracoronary alteplase. Okay, the part is this baby at this point in time was in room air with a normal blood pressure. Okay, obviously eventually would have deteriorated significantly. But this was a near miss, and were it not for the fact that we did screening, we wouldn't have realized this. I want to share a second case with you, just briefly before we wrap up, which taught us another lesson. Okay, so you've heard my opinion on milrinone. I'm going to change that slightly here. This was a 34-week infant, again, asphyxiated, had significant hypoxemic respiratory failure, was on nitric, 100% oxygen, epinephrine. And this is this baby's echocardiogram. So unlike the last echo I just showed with you, you can see the LV here looks better, but the RV is dilated and the RV is dysfunctional. So this is the classic what we see in HIE. So this baby got managed. We increased the epinephrine. We started vasopressin to optimize kind of coronary artery perfusion and to support his pulmonary hypertension. And eventually things started getting better. The TAPSE improved, his outputs improved. So by 24 hours, he had a normal RV function, and at this point in time was just on low dose epinephrine and a small dose of vasopressin. Got rewarmed, everything was fine. Unfortunately, this kid, again, bad RV function, not having a good brain, had fairly significant seizures during this time period, treated with phenobarb, phenytoin, midazolam, and eventually lacosamide. On day 7, the baby developed fairly severe hypertension. We went back and repeated the echocardiogram. And you can see that the RV is now a much more normal size and is working okay, but the LV has become very dilated and the ejection fraction was 42%, global strain was abnormal. Okay, so we are now beyond day 7, we're not cooling, the baby's kidneys have recovered. We decided to treat this baby with milrinone. Okay, we started milrinone, ejection fraction slightly improved, but still was abnormal. Okay, it should be more than 60%. Global strain to -10, it should be -18 to -20. So we increased the milrinone to 0.66. So I sat in review, and again, daily review, we talk about cases, and I could not understand this. I said to the team, what are we doing differently with this baby? Because this does not make any sense. And then one of the fellows reminded me that the baby was being treated with lacosamide. So lacosamide is a drug that certainly I don't know very much about. It's a blockage voltage gated sodium channel. It's renally excreted, but it's known to have some cardiac arrhythmia side effects. So we decided to change the baby, to take him off the lacosamide and switch to another anticonvulsant. That's all we did. We kept him on the milrinone, and his ejection got better over the next 3 to 5 days, both ejection fraction and global strain. He got extubated. We weaned him off the milrinone, and things were completely normal by 14 days. So again, lessons to be learned that not only do we not know all the answers about the relationship between heart function and the brain, many of the medications we use commonly in the NICU and some of the newer ones, there are potentially things that we need to learn. So to wrap up, so we've time for some questions. I think the physiology of HIE is very interesting. It's very dynamic. If you have RV dysfunction is the most common thing that we see, but in this situation here, this infant had severe LV dysfunction outside of the context of normal. hypertension was the clinical sign of concern. And I think that for me is something that we've learned not just in the setting of HIE. Be very wary of hypertension. It may mean that the heart is dysfunctional. And then finally, lacosamide may have unintended side effects. And this has been kind of written up by one of our fellows as a case report. So how do we move forward from here? Well, I think that the final piece, and I'm going to just put this up here because this is something that Reagan had been kind of paying attention to, is, you know, the relationship of AI. Not everywhere is echo. The babies are not always so straightforward that you know the right time to do the echo. Can we integrate AI into our work? You know, we need to recognize that the environment we work in, how we look at babies, how parents look at babies, what's important to them, what's important to us are very, very different. And there's a lot of information that sometimes we take a snapshot picture when we come look at that baby for 5 minutes in the day and we think that we know exactly what's going on, and perhaps that maybe is a simplification. In the setting of some of the common diseases, and I had to give a talk on AI and hemodynamics recently, so I learned a lot about this. But certainly what I learned is in the retinopathy literature that there's certainly emerging data that kind of AI can be useful in actually predicting severity of HIE, and this is some of the data showing based on kind of patterns of vascular development and vascular severity scores have a strong relationship between the severity of HIE. I bring that up because, you know, we have kind of, you know, through Daniel Rios, we have sickbay here, which obviously is, in my opinion, it's a giant brain that assimilates all this information that hopefully we can use to actually, you know, identify time points in which patients become unwell. It'll never tell you what's wrong, but it may tell you something is wrong. So one of the last studies that Reagan did was presented at PAS in 2023, was presented just after she passed away. She wanted to know, can AI predict the babies who develop heart dysfunction? And what you can see here very nicely, if you start to look at in particular systolic blood pressure, that there are differences in the heart function groups. Those systolic, diastolic, you know, in particular, look very different to the babies that actually don't have heart dysfunction. We're still working on this to try to come up with some form of algorithm that perhaps that you may be able to use to trigger. This is a baby in which perhaps we need to perform an echocardiogram. So, take-home points. Abnormal RV function is an important determinant of brain health. What you do on a day-to-day basis, the choices of drugs. When you decide to treat low blood pressure, what you use may actually have an influence on brain injury, but we still lack data. In the setting of HIE, you know, dopamine and melatonin are not favorable medications. They biologically don't make sense, and whatever information we have suggests that they may be harmful. We're currently looking at the impact of mandatory echo screening on neonatal outcomes and comparing our site here in Iowa to 2 other sites to see if this does make a difference to patient outcomes. These were Reagan's plans, and I put it up because she had plans to do, you know, one was to develop an animal experimental model of RV dysfunction. We've not got this sorted out yet, but I'm hoping that we can attract a young, dynamic person to do this type of work. We are looking at the impact of hemodynamics training in HIE, and then finally to perform, you know, clinical trials of adjunctive therapy once we've done this preliminary pharmacokinetic work. These were her goals. So I'm going to stop here, and I will be more than happy to answer any questions.
Okay, so thank you so much. For any questions that you've got for Patrick here, please put them in the chat. While we're waiting for questions, I'll just throw a couple thoughts and things out there. Oh, we've got one already. Would you recommend post-warming to obtain a cardiac? Oh, so would you recommend an echo post-warming?
So, yeah, so I think, but let me answer the question in a slightly different way, Clara. So echo is great, but it's only great if you get the right information. Okay, so someone telling you something that is based on eyeball evaluation, that maybe 5 different other people will tell you 5 different things. That may not be the best thing either. Certainly, what I didn't tell you is when we looked at that study looking at reliability, the reliability improved in severe. Okay, so most people can pick up the heart is dead. It's severely affected. So if you get that information, I think that's helpful. The problem is normal versus mild is where the error is going to be between people. I would remind people to think carefully about systolic and diastolic blood pressure. I think those things are really important, you know, in choosing when to treat, what to treat with. You know, classically, what you will see in the HIE babies is that their diastolic pressure is okay, but the systolic blood pressure is what falls. So paying attention to the systolic and maintaining it above the 3rd percentile. That's what we do. Even before we do our first echo, we will typically start a low dose debut infusion if that's the case, and titrate up. I think in the rewarming phase, I would remind people that that's when you need to be weaning, because if you leave babies on medications and you start to drive hypertension, okay, I can't prove it at this point in time, but certainly biologically, there's nothing good about high blood pressure and high flow to the brain. You know, so logic would say is if you can get rid of medications that babies don't need, that's a good thing to do. So that's what we do in practice here. Is once we rewarm, you know, our nurses are very vigilant in looking at the systolic and diastolic blood pressure, and then trying to wean the patients off their medications.
So just offshoot on what you said. For those of us who don't have neo-hemodynamic teams dedicated to the serial echoes and knowing what parameters to look at, how could we out in the community, what should we ask for or particularly look for in the echoes that we do have? What parameters do you think are the most important for us?
Yeah, so I would say, like, again, TAPSE is not a very hard thing to do. You know, I think if you could get your cardiologist to agree to measure TAPSE, it's an M mode through the tricuspid valve. Like that was the strongest predictor of death or abnormal MRI or neurodevelopmental outcomes at 2 years of age. You know, and I think that will at least change the field to get some more rigor around the assessment. You know, if that's the one thing that I think would help make a difference. I would not be encouraging them to measure cardiac output, because if anything, you know, in the pivotal trial, people struggle to do it the correct way. Like the angles are off, the Dopplers are in the wrong position. So I think if there was one thing that could make a difference, is TAPSE. It's not a hard measurement to do. So
the TAPSE, as you said, 13 to 18 is kind of what we're looking at, but we want to aim for above 10.
What do you mean 13 to 18?
Oh, the numbers, like how would we look at the numbers?
Oh, okay, yeah. So basically, a TAPSE of less than 6 predicted bad outcomes. Most of our babies have a TAPSE between 8 to 12.
8 to 12. Okay.
Yeah.
8 to 12 people.
Your babies, yeah.
Okay. So we've got a lot of questions coming in. So we've got also serial markers like troponin. Do we find that helpful, and how would we use that?
Yeah, so we measure troponin. The problem with troponin is it's a measurement that doesn't necessarily tell you what's exactly happening at the moment. It's like CRP. The babies get sick and the CRP goes up 24 hours later. Okay. We know that all asphyxiated babies will have elevated troponin. Okay. So we do measure it as an adjunct to look for recovery, but we would never use it for deciding who to treat.
Good to know. The next question regarding this specific kind of scenario, TH babies with HIE or any kind of encephalopathy, you had mentioned using dobutamine as one of your early, or if not first line, with low systolics and poor RV function. Would that still be your first line medication, or would you choose something else?
Right. So that's a really important question. So let me just kind of just home into this, you know, slightly differently. So when let's take the echo out for a second. So let's say we have a baby who has got low systolic blood pressure. The next question we ask is the diastolic low or normal? If the systolic is mildly reduced, we will start dobutamine. Okay. If, however, the systolic is moderate to severely reduced and the diastolic is also low, then we would use epinephrine. Okay. We will use that, you know, isolated systolic predominantly. We will use dobutamine. combined systolic and diastolic, we will use epinephrine. Okay, and then if it's really, really severe, sometimes we might use hydrocortisone in a very extremely hypotensive baby. Now, if we get the echo, okay, and we see on echo that the patient has got mild dysfunction, plus or minus low systolic blood pressure, we will use dobutamine. If the dysfunction is very severe, we will go straight to epinephrine. You know, and again, you heard I mentioned it briefly, but based on our anecdotal experiences, not based on some trial or some evidence, if you don't respond to say 7.5 mics of dobutamine, what we have found is going up beyond that, you just make the patient more and more tachycardic, and the blood pressure doesn't get any better. And what we also do is try to get them off the dobutamine. So if you got 7.5, it hasn't worked, well then why are you continuing something that didn't work? Then we just go straight to epinephrine. But you could transition, start the epi and then try to wean the dobutamine afterwards.
So we've got a request for slides with the algorithms. So I'll try to get that from you later if that's all right.
There'd be a big charge for that.
Yeah, per slide. We've got another question here, kind of along those lines. Since we're trying to avoid milrinone, given the kidney and the liver injury and such during cooling, how would we promote this afterload reduction kind of gentle inotropy? Would that be with the dobutamine or otherwise?
Yeah, so I think dobutamine is the way to go. Like again, thankfully, we don't have that many babies with very severe need for afterload reduction. There are other medications you could use in that scenario. So, for example, sodium nitroprusside. That tends to be the drug we use in babies with hypertension that have a contraindication to milrinone. Of course, that scares most neonatologists and the bedside nurses even more, but actually it's probably one of the cleanest drugs you can use because it's really short acting. And I like nitroprusside. Esmolol and nitroprusside are what scare people, but they're actually really simple, straightforward things to use.
Yeah, I think I've only used it a handful of times.
Yeah.
So we've got a question here about like if we don't have, say real-time echoes or get the parameters that you think are specifically helpful, how would you recommend like at what threshold for blood pressure to treat? You had mentioned systolics should be greater than 30 percentile. And again, the question with the first agent. Maybe this is kind of a rehash of your dobutamine epi situation.
Just say it again. I missed the first part. Sorry, someone texted me. I got confused.
Yeah. The threshold for blood pressures. You'd mentioned the
third percentile. So we use the third percentile. If you go to, I don't like advertising, but if you go to that textbook of neonatal hemodynamics, there's a section that goes through what we know on normative centiles for blood pressure, and I think we really have to move people away from the mean gestational age to thinking about systolic and diastolic, because it just is biologically, it makes you think physiologically to treat systolic versus diastolic. That's probably the greatest argument to stop using that thing that was a line in a consensus paper in 1992 with no scientific validation. So
it made it easy for us.
Yeah, we are a very stubborn group of people, neonatologists. We stick our heels into things and don't like to change.
But yeah, we're intensivists, so we're intense, right?
Yeah.
So we've got a question here about the comparing between dopamine and dobutamine. There was a slide perhaps that showed the p-value was significantly different in the watershed injury versus injury being higher with the dobutamine group. Was that correct, or do we have an explanation for that?
Yeah. So basically, kind of in the dobutamine treated group, there was a very slight difference, but the overall kind of injury, kind of in terms of severity of that, was not significant. Like again, when you look at prediction of neurodevelopmental outcomes, and you look at isolated white matter, watershed, basal ganglia, obviously, kind of the loss of the plaque with basal ganglia injury are the two most severe things that you see on MRI. I think basically what we're seeing there is that, we know these kids are going to be asphyxiated. We know they're going to have some form of injury. The pattern is different. To tease out why is the basal ganglia piece more severe, And why might there be so differences in watershed on a single site study is really, really, difficult. But I think the message that I want people to take away from that is that, the medications we choose may have an influence on the severity of the brain injury. That's the main message.
And then perhaps this might be our last question. Rules and indications for the use of vasopressin as well as norepi in these kind of scenarios?
Yeah, so the answer is how severe is the pulmonary hypertension, how much oxygen do you want? And again, I would just bring everybody back to the literature we have on comparing vaso and norepinephrine. And there are two pieces of literature. There's the animal data from Satyan's sheep model, which showed that in hyperoxic environment, on high oxygen requirement, norepi is more of a pulmonary vasoconstrictor. But the best study we have in humans is a randomized trial done in the cath lab where kind of infants and young children were random. They received milrinone, both groups, and PVR and SVR dropped. They then were randomized to vasopressin versus norepinephrine. And what you saw that in both groups, SVR went back up. But with PVR, the PVR remained low with vaso, but went back up to the pre-milrinone treated levels with norepinephrine. So I think that's what we typically use. If the oxygen requirement is low, less than 60%, we're okay to give norepinephrine. If it's more than 60%, we'll use vasopressin.
Okay. That seems very clear. I've got one more if you can keep on. Sorry, two more. Morphine and Precedex, is there an impact or a preference on cardiac function during?
Yeah, it's a great question. Like, all I would say is whichever you use, be cognizant of the fact that metabolism is impacted. There was Annika Roca is a Hungarian neonatologist who did a study comparing the pharmacology of morphine and demonstrated that you can get fairly significant hypotension with much lower levels of morphine. That's the best evidence we have. In comparing morphine versus kind of Precedex, there's not much out there. All I would say to people is if the injury is more severe, you probably will need lower doses of sedation.
And a question about, the use of sildenafil, particularly in the setting of significant pulmonary hypertension and RV dysfunction. Should this or could this be started with epi / it's a here, but I know you want dopamine now.
No, I think it's if you've got significant pulmonary hypertension, you treat the pulmonary hypertension. And that's where nitric oxide kind of would be the standard approach to pulmonary hypertension, but not everywhere has nitric oxide. So if you don't have nitric oxide, then sildenafil, I think, would be a very reasonable thing to do. The other point is oh my God, Pia Wintermark's work in animals in Montreal shows that there may be a protective effect of sildenafil to the brain. What we don't know from Pia's work, and I've asked her, is it because of its effect direct on the brain, or could you be modulating RV function? Because if you decrease the afterload to the RV is going to get better. So could it be both? So I think Gabriel is going to help her with some echoes and animal stuff to try to figure that piece out.
Oh, fantastic. Okay. Yeah. Next person we're gonna bug about this. Any more questions? If not, I'm gonna say thank you so much to Patrick. You are our new annual speaker, so maybe I'll come at you next year for something.
Yeah, it's not fun being the annual speaker when it's February minus a million degrees here.
Yeah.
Webinar. I'm happy to be the annual speaker in person in February in California.
So it's out here. It's in the recording. Dr. McNamara would like to come see us over in Southern California. We'll try to make that happen. Thank you so much. We really appreciate it. Thank you to Reagan and all her work.
Thank you guys for allowing this to happen and to be so supportive of Reagan. Okay.
Yeah. Yes. Thank you so much. Yeah. We'll see everyone next month. We've got another great speaker on the third Tuesday. We're going to be talking about salsa, supraglottic airway. Bye, Patrick. Thank you. Oh, and don't forget to fill out the survey for CME and MOC Part 2.